be next week. And in terms of the readiness of the plans, we have 6 countries, that's category 1 countries in terms of risk, that have all prepared their plan. The plan of South Africa is still in the draft form, but very soon it will be also finalized. At the same time, we have already 2 countries that are vaccinating, that is Rwanda and DRC. And the good news in both countries is that the coverage rate is very high. Rwanda has achieved 100% of the target, and DRC has even exceeded, in some places, to reach 103% of the target. And most importantly is that when you look at the breakdown of the data, we see that healthcare workers are among those that have really exceeded the target of 100%, which is good news when we compare with the situation during the COVID outbreak, when health workers were actually the drivers of vaccine hesitancy. Next. Just also to say that, no, let's go back to the previous, that now we have 5.6 million doses of vaccines that are pledged. Next slide, please. No, the previous slide. Previous slide. Yes, there. This week, as I said, we have made an allocation of 899,000 doses that were allocated to 9 member states. I think that is the first round. Right now, we are preparing the second round of allocation in November with another 700,000 MVA doses that are also scheduled to be available between November and December. I have to say this is really good news that all the partners could come together and look at the criteria that we agreed and also the readiness of this country to be able to make a decision to ensure fairness in the distribution of these expensive vaccines. Next. Now, when we look at the disaggregated data from the DRC, is that those provinces, the 3 provinces that started vaccinating 4 weeks ago, all of them have achieved very high coverage. And then we are monitoring the situation in the 3 provinces that started from the 15th and the 17th that are still vaccinating right now. But when we look at the level of coverage that have reached, it's quite encouraging that these provinces are also on track. In North Kivu, I think vaccination has also started in congested settings, that is in prisons, in IDP camps. We remember the presentation that we had last time that we've seen our cases also being reported in these places that they have been included as part of the priority groups for vaccination. Now, in terms of the priorities in this area is the vaccination of Kinshasa, which is scheduled to start on November 6th. I think that is really underway. We're already working with Bavarian Nordic, with HERA and UNICEF to deploy the 166,000 doses of vaccines that they want to cover the city of Kinshasa, which we have also seen a rapid increase of cases. Next. Now, on the financing side, on the pledges, I think we have to say that we've done very well. You remember that the Continental plan was budgeted for 599 million. Now we have 1.3 billion in pledges. I think that includes 500 million from the US government, include also 217 million from CEPI, and the pandemic fund for Mpox, 129 million. And remember that the pandemic fund, there's also the other 321 million for pandemic preparedness and response, and also for health system strengthening for resilience that could also be leveraged again to contribute to the Mpox response. There to say we are doing very well on pledges. With similar also on the domestic resources, we've seen goodwill from a number of governments. The DRC government has also placed to allocate 10 million. In Burundi, where we are right now, 1 million. We've also seen same also commitment from Gabon, from Cote d'Ivoire, and from Rwanda. Now, on the vaccines, as I said, almost 6 million doses of vaccines that are being pledged as well. But now what we need is the continuous political and financial mobilization. Very importantly, is to get to the point where these pledges can be translated into commitment and disbursement of funds. But also to ensure transparency and accountability on our side, we've also established the financial tracker and the dashboards that will allow us to track every dollar that comes, how it is being used for the Mpox response. Next. The same also, when we go into the details now, try to look at the needs and the pledges. In general, when we look at Cote d'Ivoire, Kenya, Uganda, and also some partners like UNICEF, the World Food Programme, and WHO, we see that the budget that was estimated has been kind of met or exceeded, I think, for many of them. But where we still have a big gap, it is in Burundi, where we have the budget of 15 million, but so far it's only 9 million. I think that has been placed and committed. I think most of this money comes from the pandemic fund. We have Africa CDC also, which had a budget of 58 million. So far, only 18 million mobilized. That is 1/3 of the budget. And DRC, likewise, 171 million. They budgeted for only 48 million so far pledged. And Central African Republic, 13 million. They budgeted for only 1.9 million pledged. And our IOM, out of the 28 million, they also pledged only 2 million pledged. I think those ones at the bottom are the ones that we are prioritizing as we move forward with the resource mobilization to ensure that also they have the resources they need for an effective response. Next. Finally, in summary, we'd like to say that the cases of Mpox on the continent are still increasing, with more countries affected, and also with mixed modes of transmission. And that what we need now is to intensify the response. On the main pillars where we've observed most of the gap, it's in the area of surveillance. We need really to shift toward active surveillance, and on the area of testing, in particular in the two Congos, we need to move toward universal testing to be able to reach the minimum of 80% target. In the area of risk communication and community engagement, extremely important to really push the behavior change and especially the adoption of infection prevention and control measures, both in the health facilities, in the schools, and also in the communities. And vaccination, I just started in these two countries. We have now 9 countries who like really to push vaccination as an additional intervention to the package that we've been promoting. And holistic case management, also extremely important. In Burundi, where we are right now, we visited the centers. We've seen what this holistic case management can really produce. 0 deaths for more than 1,000 cases that have been taken care of. And to finish, I think we need to continue mobilizing the political engagement and also mobilizing the financial support that is critical to get the current outbreak under control. And especially that we do not want this Mpox, especially the clade 1B, to become another sexually transmitted pandemic, which could be much more severe than COVID-19. Thank you very much for attention. Back to you, Director.
Thank you very much, Dr. Ngashi. Let's now cross over to the Honorable Minister of State of Rwanda, Dr. Ivan Butera. Over to you, Honorable Minister.
Thank you very much, Margaret. Good morning, everyone. Thank you for joining us today. I'm here to share updates on Rwanda's response against the Marburg virus. It's been a little over a month since we detected our first lab-confirmed case of Marburg. And as of today, now we have 66 confirmed cases. We've recorded 4 new cases in the last 2 weeks. So our epi trend is leaning towards few cases being detected over time. And in terms of death as well, since the beginning of the outbreak, we recorded 15 deaths. But over the last 2 weeks also, only 2 deaths were recorded. I think now we are at a case fatality rate of 22.7%, probably among the lowest ever recorded. And we have 14 people that have already recovered from the virus, including 2 that recovered yesterday. So in terms of testing, we've been expanding our testing capacity, and so far we've tested close to 6,000. These were mostly people at risk, but also contacts of positive cases. And as you know, we also started vaccination, and so far we've vaccinated a little over 1,600 people. We still have contacts that are being followed as a result of our contact tracing, and we have, as of now, 559 patients that are contacts that are being followed up. So I think, like we've been discussing in previous presses, the priority really is for rapid detection, rapid testing, quick isolation, and treatment of positive cases, as well as well-spread infection prevention control measures and other measures such as vaccination and therapeutics that have been distributed, I think have contributed to the result that we're seeing right now, which is a well-controlled outbreak. So I thought I should just give you what has happened in these few days since we last met. And I'd like to conclude by affirming that Rwanda is committed to contributing to the global knowledge pool of Marburg and similar threats. And please consider Rwanda as a resilient and innovative partner in global health, but more particularly in global health security, as some of these diseases have a potential of becoming a bit serious for many more people. But in short, I think the outbreak is not yet over, but I think in terms of be it the numbers that we're seeing, be it the number of contacts that are being followed up, the positivity rates that we're seeing, I think we are headed into the direction. It's not yet time to declare victory, but we think we are headed in the good direction. I'll pause here, moderator, and over to you. Thank you.
Thank you very much, Honorable Minister. Let's cross over to the floor for questions. I see Sarah Jervin from DVEX. You have the floor.
Taking my questions. I have 2. I'm wondering if you can please elaborate on the commentary on how Mpox could be potentially more severe than COVID-19, given that COVID-19 can be transmitted through air. And then I'm wondering if you can also give an update on the status of the new Africa Epidemics Fund, how far it is from being operationalized, and in the future, what kind of role will it play in emergencies like this? Thank you.
Thank you very much. Let's take one more from the floor. Helen from START, you have the floor.
Thank you very much for doing this, and thank you for taking my question. My question is for the Minister of State, Dr. Butera. Dr. Butera, I was wondering if you could give us some idea about the number of probable cases you've had in your outbreak. The recent few cases, I think, have been people from the community, not healthcare workers, so people who were around the index case, which would kind of suggest that there has been ongoing spread potentially in the community. So if you could flesh out the picture for us a little bit, how long are the chains of transmission around the initial case, and just how well do you think you have a handle on what has been happening there? And one other question, if I could please, you mentioned that 2 people were released from the hospital, or were deemed recovered yesterday, was one of them the healthcare worker who had been vaccinated? Thank you. Oh, third question. You're almost out of vaccine doses, I think. Have you any additional supply coming? Thank you.
Thank you very much. Let's take the first responses from the Honorable Minister. Over to you, Dr. Ivan.
Thank you very much, and thank you, Helen, for these great questions. So for the 4 new cases that we have reported in the last 2 weeks, one was a healthcare worker that had been working in a treatment center for some time, in fact, since the beginning of the outbreak. And the other 3 cases were contacts of patients that we had been following. And what we have been discovering in this outbreak, and probably we will revisit the data when time comes, is that the incubation period that we talk about that goes up to 21 days, we might have seen some cases that go beyond that. But all the other 3 cases that we're talking about here are contacts of known cases, including one that was linked to the index case. So I wouldn't say that we have evidence of unknown cases in the community where we have community transmissions, because we've also put an initiative that we call door-to-door campaign, going every household to household from zones that were known to be potential risks. And so far, we haven't had a single positive case from our door-to-door activity. So all the positive cases that we have a clear AP link from non-transmission chains, and no evidence so far of cases that don't necessarily fit into what we have established as a transmission chain. So far, we have 1 cluster with 3 main branches. The 3 main branches are, one is a large teaching hospital, another one is also a teaching hospital, and another cluster is linked to our index case. In terms of the healthcare worker, yes, the cases reported yesterday includes one of our healthcare worker that we're happy that has recovered after testing negative from 2 PCRs. It's 2 hours apart. We don't have evidence yet that is, we are still ascertaining whether she was exposed, the right time she was exposed, because days are quite linked. She might have been already in an incubation period. So we are still looking and analyzing her case to exactly ascertain where she might have been exposed, the moment, and see the link with vaccination, but we haven't concluded that investigation yet. It's true that of the 1,700 vaccines that we had received, we have used more than 1,600 now, and we are in talks to see how we can acquire more vaccines. So hopefully we should be able to get additional doses, and we'll update as soon as we get more news in that angle. And thank you, Helen, for that question. Back to you, moderator.
Thank you very much. Over to you, Dr. Ngashi, for the questions from DVX.
Yeah, thank you very much, Sarah, for those great questions. I think the severity, I was referring to the case fatality rate, that has been quite high, especially in the context of very weak health system like what we see in DRC now, where they have moved from 4%, although it is now going down to about 2.8%. So it is for the experience of your question about epidemic extremely important. I think things are quite advanced because the process is that it has to be submitted through the commission and then go through the AU organs. I think that is quite advanced at that level. But we are also using the opportunity of Mpox to again motivate for accelerating the process, given the fact that we were in a situation where even the leftover of the COVID-19 funds were not immediately available because the fund was not yet established. But then we have to get an exceptional approval of the Permanent Representatives Committee to allocate part of this fund to the Mpox response. I think that's the 10 million that you heard about. But if we had a fund that could have taken all the COVID fund into the Africa Epidemic Fund, things could have been much easier. But that is already in the process. We are hoping that by the next assembly in February, we could get to some good decision on the Africa Epidemic Fund. Over to you, Director.
Thank you very much, Dr. Ngashi. Let's take the next two questions. Coming from Politico, you have the floor.
Thank you so much, Margaret, for taking my question. I just wanted to ask about so basically the next batch of vaccines of Mpox that need to reach the DRC and the other countries. You mentioned something about an allocation plan and about November and 700,000 doses. Will those mostly be coming from the U.S. pledge of 1 million doses, or sort of like, what's the plan for that? And I was wondering how many of the, I think, 250-something thousand vaccines that the DRC had received, how many of those have been used already? Thank you so much.
Thank you very much. Let's take the next one before the responses come in. Kerry from Health Policy Watch, you have the floor.
Thank you, Margaret. I have two questions, if I may. The first one is related to Uganda. The outbreak started in a prison, as far as I understand it. Now there's 61 cases. So I wondered whether perhaps Dr. Ngashi could maybe just expand on who those cases are. Are they mostly prisoners, or has it spread further? And then the second question to both the speakers is, the pandemic talks start again next week. And here you are both sitting, dealing with practical outbreaks. So is there anything that you would like to tell those who are negotiating for a pandemic treaties, things that would make your lives easier in terms of global support for outbreaks that could become pandemics? Thanks.
Thank you very much. Let's start with the Honorable Minister for that question, and then we move to Dr. Ngashi. Over to you.
Yes. Thank you, Kerry. Well, I think the important thing that we've continuously learning is that we are prone to shocks at any time and anywhere. So the capacity to be able to prevent, to rapidly detect, respond, and deploy innovative tools in terms of preventive ones or therapeutic ones, or otherwise diagnostics, etc., is extremely important. And another part is to be able to share the knowledge that comes out of what we see, so that it can shape, be it better policies or better tools to contain and control future diseases that have potential to become outbreaks, epidemics, or pandemics. So it's just a matter of being able to work together collaboratively to handle these situations efficiently. Over to you. Thank you.
Thank you. Dr. Ngashi?
Yes, thank you very much, Carmen, for those questions. I think if I start with Uganda, the case of Uganda, the initial cases were cases that were imported from the DRC. I think those were travelers that came from the DRC. And then sporadic cases were reported in 4 districts, starting with Kasese, which is right at the border with the DRC. But now, as I presented, the cases have now spread to about 19 districts. There is now community transmission, of Mpox, in Uganda. That explained that they have reached about the 830 suspected cases and 152, I think, that are confirmed, that are reported. That is because it is now community transmission, I think, in at least 19 countries in the country. And then on the question about DRC, the DRC, they received 265,000 doses. They have used now almost 50,000 cases, 50,000 doses. And I think the vaccination is ongoing in those 6 provinces. Looking at the absorption rate, I think they are expecting that they should be able to absorb at least 200,000 of those of the initial request. That's the reason why out of the 160,000 they have requested for Kinshasa, they are hoping that there might be something like 50 to 60,000 leftovers. That's why the new requester of additional doses is talking about 110,000 doses. Just to say that the absorption is good as they are progressing in those in those 6 provinces. They are really hoping that they absorb all the 200,000 doses, and also at Kinshasa, that will increase to the numbers. Now, about the pandemic talks, I think, just to say that there were a lot of meetings, I think, that have been going on, both with the ministers of health and also with the negotiators to try and find, a solution on some of the major controversial issues where that blocked the initial approval of the pandemic treaty. And we are hoping that the flexibility will be on both sides as well. I think we've learned one lesson is that when you are negotiating, there's always something to give up and something to gain. But we like also, the hope is that the same approach will be also used on the other side as well, because some of these issues like benefit sharing, I think that really resonates that if you have used the viruses and pathogens, from an African country and use that to develop vaccines, it is really common sense that in the distribution of the medical countermeasures that come out of that, those that also contributed with the pathogens also get a share of that because of the fact that they are also equally quite affected. Perhaps the lines were a bit hard, I think, at the first time, but we are hoping, not everyone is hoping that now with everything that has gone behind the scenes, I think both sides will be able to come to a compromise. But some of these things are extremely important that we can't just let them go, but it's really finding a middle ground that everyone feels that there's also something to gain, in the negotiation. I think that's the most important. But rest assured that the work continues. The negotiators are no more alone, as it was at the beginning. It is both Africa CDC and our leadership, Continental leadership, health leadership, that is also supporting and guiding. As you remember that there was even a meeting that was convened in Addis, where all of them came to Addis, and then we had an opportunity to also listen to them and also guide the process how we can find a compromise. We are hoping that this time it will work out. Over to you, Director.
Thank you, Dr. Ngashi. Let's take the next 2 questions. Kemo from Mano Reporters, you have the floor.
Thank you. I am I'm connecting from Freetown. We are neighboring Liberia. And I noticed, according to a presentation, Dr. Ngashi, Liberia is one of the 2 countries realizing increase in cases. And I also realized, I've noticed in your presentation that Liberia is not among those countries that have are either vaccinating or have a vaccination plan. And I've been monitoring what is happening there, and I'm not seeing it being discussed like a country that is really realizing cases. So I'd like to know if you can just a little on what is happening there. What are the authorities doing, especially with regards to vaccination? Thank you.
Thank you. Let's take the next one before Dr. Ngashi comes in. Gabrielle Emmanuel from NPR, you have the floor.
Thank you. I had a question regarding, you mentioned just how low the death rate is for Marburg in this outbreak. And I wanted to see if you could spell out kind of what's behind that or why that's been achieved this time. Thank you.
Thank you very much. Dr. Ngashi, over to you.
Yeah, thank you very much, Director. On Kemo's question about Liberia, what has happened that Liberia was not among the priority countries during the first prioritization that went into the Continental plan. The 6 countries that I've presented are the ones at the time that had active cases that really justify for them to be considered as high-risk, category 1 high-risk countries. the focus was on that phase 2 group of those 6 to make sure that they are supported, they get the plan, and launch the vaccination. We just did another, we revisited the categorization of countries 3 weeks ago. And then Liberia and Kenya were also identified as countries that were moved from category 2 to category 1. That's the reason why you see that there are 2 things that are happening now in Liberia. On one side, on the technical side, we are working with the country to support them to develop a plan. At the same time, they have already been included in the allocation. I think they're among the 9 countries that have not received an allocation of vaccine, which means the vaccines are now available for them as soon as the country process is completed. Liberia is one of the 9 countries that will also embark into vaccination. Now, the second question about zero mortality that I mentioned in Burundi, if that's what is being spoken about, Burundi's strategy is to evacuate and isolate all the confirmed cases and take them to the treatment centers. We visited the treatment centers here, really holistic with support from a number of partners, WHO, UNICEF, World Food Program, a holistic approach to treatment that includes clinical care, it includes nutritional support with food supplementation, and also psychosocial support. I think it is the combination of the early identification and isolation and the comprehensiveness of the care. Also to mention that they are really receiving very good support in the treatment centers. I think that's what explains the quality of the care and the outcome. I think that is the 0 cases that they have had so far.
Thank you very much. Honorable Minister, there was a question for you.
Correct, yes. Gabriel Emmanuel from NPR about the case fatality rate. I think it's a combination of action. One is, I think from a preparedness perspective, we had been building capacity in terms of infrastructure, but also personnel for ICU and emergency medicine, internal medicine, and everything that goes around it. So our critical care capacity had been prepared to deal with highly infectious disease or severe diseases such as Marburg. Number 2, I think rapid identification and rapid testing and isolation of patients led us, and a quick turnaround time from a laboratory led to detect cases quickly and provide them with treatment in the very, very early phases of their diseases. I think it has been helpful to treat early, be it in terms of supportive care, but also deploying some of therapeutics also helped us, particularly for this outbreak. We were able to deploy an antiviral, remdesivir, but also monoclonal antibodies as well. I think provided some good support in terms of response to the outbreak and taking as low as possible the case fatality rate. Additionally, I think touched upon it earlier, some of the cases that were critically ill, we were able, by a multidisciplinary team with strict infection prevention control and adequate care, we had 2 patients that were actually intubated and on mechanical ventilation. They are receiving respiratory support, and we were able to wean off the respiratory support, and they were actually extubated. In fact, both patients have recovered. I think it was probably the first time on the continent that we recorded 2 patients that were intubated that recovered from it. So I think combination of clinical care, but with public health interventions, strong detection, rapid response, isolation, treatment, contributed without a doubt to this relatively low case fatality rate that we've seen. Thank you. Back to you, moderator.
Thank you very much. Let's take the last 2 questions. Priyanka, you have the floor.
Thanks, Margaret. This question is for Dr. Butera. I was curious about animal surveillance. So ever since the knowledge about the index case being connected to a particular bat population in a cave, what does ongoing animal surveillance look like? Is it mostly surveying bat populations and caves in areas nearby to that particular cave, or is it a larger countrywide animal surveillance plan? What does that look like? And just curious about this particular cave, is it close to Kigali? Is it far away because, the clusters are around there?
Thank you very much. Let's take the last one from Paul from Lancet.
Hi, thank you very much for this opportunity. My first question takes it forward from the last question, which is, do we have an update to what the official account regarding the index case looks like? And the second question that I have has to do with what is currently the level of interactions between the Africa CDC and African countries with the countries in Europe that have already confirmed cases. And my very last question has to do with the rapid increase in the number of toolkits available to respond to Mpox disease. Can we attribute it to this emergency calls, both by the WHO and Africa CDC, and how do we ensure that we don't need an emergency declaration for us to accelerate the expansion of available toolkits to respond to outbreaks? Thank you very much.
Thank you. Let's start with the responses from the Honorable Minister. Over to you.
All right. Question from Priyanka in terms of surveillance. So we were able to trace back that the index case was in fact exposed to a mining cave where we know or we found that the known reservoir or host for Marburg virus disease, which is typically fruit bats, were found there. So we have evidence that were exposed there. So in terms of surveillance, we put a clear-cut demarcation where these bats reside. There's no longer contact with humans. In addition to that, there's been a comprehensive mapping of all the potential sites that might harbor some of these fruit bats in a One Health perspective, working with other agencies that work in this field. We have been able to map all the sites and put in place preventive and secure measures where you don't have human to bat interaction to prevent future events. And we'll continue also work to understand the period of shedding of these particular fruit bats. There's some evidence from the past that it is particularly seasonal, where you see in other experiences around Feb, March, and again in August, September, where you see an increased period of shedding, which coincides with what we saw here. So there's also going to be continuous monitoring in that area to continue surveillance of these known hosts. And in terms of the index case, like I talked about, so we went back. We have evidence that the index case relative was exposed and was the first point associated to our healthcare workers in one of our teaching hospital, which was kind of epicenter at the beginning of the outbreak. But now tracing back, going back, seeing that the index case actually was someone who was exposed at the mine, and a particular mine where you have these fruit bats, I think. And after that, we saw one more patient that was exposed in that area as well. So that cave is near Kigali. Rwanda is a very small country, so the mine cave is a little bit outside the city. I think those were the questions. Thank you.
Dr. Ngashi, over to you.
Yes, thank you very much, Paul, for those very interesting questions. I think on question number one, what interaction we have with European countries, right from the beginning of the Mpox outbreak, I think at the time of the declaration, we got in touch with Europe, with America, with Asia, with similar institutions. We are working very closely with the European CDC, collaborating very closely in areas of surveillance, in particular of laboratory strengthening, where on one side we understand is in this globalized world, I think knowing that there are so many pathogens that come out of Africa to go to other places, and that the best way that we can is really to work together to make sure that we have a strong response in Africa that can help us really analyze these pathogens on a regular basis. That's work that we do with European CDC, but also come up with an agenda how we are going to respond to that in terms of the capacity that we need to build on one side. On the other side, also the medical countermeasures that will be needed to respond. I think touching also to your second question. Right now, we have a team of EU CDC that is seated with us in Kinshasa as part of the Continental Incident Management Support Team. I think that is providing the technical support to the member state and to the team. And I think that is the team also that links with what is happening in Europe, that brings that information back to us, as some of the cases are due to travel from some of the affected countries, so that we can then strengthen the interventions in those countries, especially the surveillance, especially surveillance at point of entry, to make sure that the action of prevention starts right from the source of these cases, where they come from. We also have even some technical experts from some specific countries. For example, the UK Rapid Response Team is also now with us seated in Kinshasa, just to coordinate, to make sure that we can link what is happening in Africa with what is happening in Europe as well. I think that is something that we are going to continue, so that as much as they are responding in Europe, they are also supporting the response here as one way of preventing then more cases also getting out of Africa to go to Europe. Now, on the issue of the rapid expansion of available tools, we have used different strategies. I think one is the current advocacy to really increase the production, to lower the cost, and also increase the access of those tools to all those that need them, especially in Africa, to ensure that there's equity of access. But at the same time, we are also looking at the long term. I think that's why we have an agreement that we've signed with Bavarian Nordic, for example, where what we are negotiating is to link these tools with the local manufacturing agenda, so that in the long run, Africa is able to produce those tools locally, at affordable cost, so that in case of high demand, we still have the capacity to provide for ourselves. I think those are some of the efforts that are ongoing collaboration with WHO and Africa CDC, working together, even with some of the local institutions in Africa, to ensure that we can produce those tools in the future for ourselves on the continent. Over to you, Director.
Thank you, Dr. Ngashi. Let's take the last one from the BBC. Dorcas, you have the floor.
I have two questions. One, we understand that Nigeria postponed the Mpox vaccination. When is that likely to happen? And you mentioned that Uganda's situation is concerning. The last time Africa CDC said it allocated 2,000 doses to Uganda. Now with the current situation, do you plan to allocate more?
Dr. Ngashi, over to you.
Yes, I think the situation in Nigeria came to us. I think we're informed that it is the readiness. I think that has been an issue. Now we are working with Nigeria to see how we can identify those specific challenges that they are facing, really, to launch the vaccination and then help them to launch. We haven't received any date yet. I think as soon as we get a date, we'll be able to communicate that. For Uganda, yes, Uganda is one of the countries that was prioritized for allocation of vaccines. Now they've gotten much more than they requested. The only problem that I know the numbers, but I can't disclose them now, because the process is that once we make a suggestion to the technical review committee, which then makes recommendation allocations, then that is signed off by Dr. Tedros, Jean Cassé, and Sanya and UNICEF. And after that, we communicate with the countries. It is only when the countries accept that we can make this information available. I think that's where we are now at that step of communicating with countries. As soon as Uganda accepts, we'll be able to tell you. But the bottom line is we've provided much more vaccines now at this time because of what is going on in Uganda to help them really fight this outbreak.
Thank you very much. And with that, we've come to the end of the briefing for this week. Dr. Ngashi, I'll pass it over to you for your closing remarks.
Thank you very much, Director. I would like to really thank all the participants. I think these meetings are extremely important. The question that they ask and the feedback are things that also help us, refocus our response and also know exactly how we can guide our priorities. We also encourage that even outside these press conferences, we are available. I think at the same contact. Do not hesitate really to get in touch with us if you have any question, any suggestion, any comment. I think we are there to work for you and give you all the information that you need. It's something that concerns all of us. I think we take it that we are together in it, and we appreciate all the support that you provide to the teams that are working on the ground. Over to you, Director.
Thank you very much. And with that, we've come to the end of the briefing. We'll see you again next week. Thank you.